Welcome to the Healthcare Voice of the New Right Network. This is Stealth on Health with Mario Nacinovich. Envisioned by the people, voiced by the people, powered by the people. It is everyday people with extraordinary values that make up New Right Network. Welcome to the Healthcare Voice of New Right Network. This is Stealth on Health. I'm Mario Nacinovich. Joining me for our episode is Dr. Evan Cohen, Medical Director and Chairman of Emergency Services at Montefiore St. Luke's, Cornwall in Newburgh, New York. Dr. Evan Cohen is an emergency medicine physician serving the New York City area for more than 10 years. He's board certified in the American Board of Emergency Medicine. He received his bachelor's degree of science from Syracuse University in 2003 and graduated from the State University of New York Upstate Medical University in 2007. He completed his residency in emergency medicine at Cooper University Hospital in Camden, New Jersey in 2010 and has been in practice for the last decade. Welcome to the fourth episode of Stealth on Health, Dr. Evan Cohen.
Thank you, Mario. Thanks so much for having me today.
The practice of emergency medicine has really changed and expanded over the years. Years ago, patients received very limited workups in the emergency department and were admitted as inpatients for their evaluations. Today, much of that evaluation and investigation, which was previously performed as inpatient, is actually now done pretty routinely in the emergency department. Dr. Cohen, to start us off, what changes have you witnessed that are now really routine in the ED?
Sure. Well, I think going back even a little before my time, really before the 1980s, most emergency departments were staffed by surgeons or internists, physicians that had left their practices for a change of pace. And so they were learning on the fly how to deal with emergency patients. In the 1980s, emergency medicine became its own specialty, and we had specific programs designed to teach people how to practice that way. And so over the past few decades, there's really been more of a uniform education and training to specifically deal with that. So, I think it's been a very exciting time for emergency medicine, and, to the point that now, except in really rural communities, most ERs are staffed by board certified trained emergency doctors that specifically know how to deal with a wide variety of emergency complaints.
So we shared a little bit of history here of how it was typically staffed a couple of decades ago. You mentioned the board certification. I think that's critically important for our viewers to understand. These aren't doctors that have elected to be there. These are people who are very much studied in the art and science of emergency medicine. Beyond the actual physicians themselves, how is the modern day ER staffed?
So again, it varies depending on your geography and population density, how close you are to a city. But for the most part, most ERs in this country are staffed by a board-certified emergency physician at least 24 hours a day, and that'll vary depending on how big the ER is, how many patients they're seeing in a year. But that's really a bare minimum in all but very rural communities. And in addition to that, most ERs will have collaboration between ER physicians and a PA, a physician assistant, or a nurse practitioner.
Now, are they specialized in emergency medicine as well? Is that a specialty for them?
There's some variability. There are residency programs for PAs and nurse practitioners where they can specifically train. A lot of them do that, and some of them are doing their undergraduate training and learning their skills and then learning specifically emergency medicine on site, on the field.
So people can feel rather confident walking into an emergency room when they're going through the initial screening and then they're being prepared, or maybe some diagnostics are being done, some histories are being gathered before they see the physician, that these are people that have truly dedicated their career to physically being in that department.
Yes, absolutely. I'd say now everybody that's working in the emergency department, that's their primary responsibility, and they've spent a lot of time learning those skills that are needed.
That's fantastic. Let's talk about a very fancy French word that I'm sure a lot of our viewers have heard. Many are perhaps confused by. Some may misinterpret. That word that we hear quite often on television that's rarely ever explained, but we see the actual activity occur. What is triage? What happens? And why is this so critically important to what you need to do next?
Sure. So triage really means that you're assigning an acuity to the patient. So most ERs will use a triage system of 1 through 5, one being that really critical patient that's having a stroke or a heart attack or a stop breathing. And those people need to be seen immediately because seconds or minutes are going to make the difference between life or limb and death or loss of limb. All the way down to level 5, which is really a very minor level of acuity. We think of someone who's there for a medication refill or a bug bite, something of that nature, that really could wait, hours, days if needed, for that patient to be seen. And it's so important, we staff our ER to match the volume that we think we're going to get on that day. And on average, we're pretty good at it. But, there are many times a day, a week, a month where the volume and the amount of available staff, nurses, doctors, PAs doesn't match up. And in those times, we need to be able to prioritize who's the sickest person, who needs my attention right now. And
Understood.
that's the value of triage. So most of the time, even those people that are level 5 that are not that sick are going to be seen pretty quickly. But during those really busy rushes, it's important to prioritize those sick patients. And then throughout our day, we're really triaging, every minute, every hour of the day to prioritize, what do I need to do next? Do I need to go check on bed 2? Do I need to talk to the family member? Do I need to, work on my chart? And we're constantly re-triaging our priority list.
So this is a constant re-indexing of sorts according to that numerical system. We've heard a number of other words beyond this indexing system. The words like emergent and urgent and semi-urgent and non-urgent. Are these commonly used in the U.S.? Is this more common as a global terminology? How do you define some of these words?
Yeah, they're commonly used, and I would equate it to how we think about triage, where an emergent patient is someone that needs your attention right away to stabilize them, and then all the way down to non-urgent is someone that it probably could wait until they see their primary doctor the next day if needed. And obviously, we look out and care for all those patients, but it doesn't impact what order we're going to do that in.
Understood. Understood. Now, how, if any, have these definitions shifted for you and your colleagues, or have taken on perhaps new meaning in terms of the emergence of the coronavirus?
Well, we've done a tremendous amount of thinking and preparation for what it was going to mean as we waited for our peak of COVID. And what we expected to happen in a lot of ways did happen, which is the percentage of people that were in that emergent category really went up. We saw a lot of patients that were very sick and were triaged as emergent or level 1s and 2s. And the percentage of people that had minor complaints went down, and appropriately, people have looked to their leaders and listened to their leaders. And, when they had that medication refill, they didn't come to the ER. And so the percentage of people that were really sick definitely went up during this crisis.
And that's really appropriate for my next question. And I'm sure many of our viewers would love to know the definitive answer to this. When should someone go to the emergency room versus urgent care? Certainly not for a refill.
Sure. So, how many hours do you have to talk about this? Because I think about this all the time. I've thought about writing a book on it. It's just such a complex topic. And we say it all the time to our colleagues, why did this person come in today? Or on the other side, that person should have come in last week. Why did they wait so long? It's
Right.
really hard to get it just right. And there's a lot of nuance to it. And even as I'm maybe giving some advice to friends or family, it's not always so clear cut. But the really clear cut, things I think are just the basics, thinking about, organ and life threatening things like stroke, heart attack. If you're having chest pain, if you're having short of breath doing a simple task like walking to the bathroom, you need to come in. If you feel like your arm or your leg has gotten weaker, or you're having facial droop, or you're having difficulty speaking, you need to come in. And if you feel like you're going to pass out, especially if it's associated with something like chest pain or short of breath or heart racing, you need to come in. And I think everything else is just this gray zone, and it really depends on, how severe your symptoms, how long they've been going on, what else is going on. The safest thing is if you don't know, you come in and we're happy to make sure that you're okay. And if there's some gray zone, maybe you call your primary doctor and, get a little bit of medical advice on that matter.
No, excellent. I agree with you. Let's also agree to continue with this kind of public service message or two at this stage of our conversation. So I just want to be really, really clear with our viewers. What is literally the first step of what people should do when they're experiencing chest pain, or in some cases, it's back pain forward? I know as a traditional symptom in women.
Sure. So, if you're experiencing something that is concerning for a heart attack, like chest pain that's lasting more than a few seconds, the first thing is to call 911 or ask a friend or a family to call 911 and come and see us. There's very few things in medicine and emergency medicine that are as time sensitive as a heart attack or a stroke.
Mhm.
Those are conditions that really have great treatments, but they're extremely time sensitive, meaning if you wait too long, the treatments become much less effective. And so those are things where we really want people to come in as soon as possible. And by ambulance, you shouldn't be driving yourself to the hospital.
And let's talk about stroke as well. So there's a lot of things to be discussed in terms of what people believe may be a stroke. What are those telltale signs, and what are those immediate actions that a potential patient should take?
I think the most straightforward and concerning ones are if you're having difficulty with your speech, it's either garbled or it doesn't make sense. And that's something that probably a friend or a family member would have to notice in you and help you. But if you're noticing those problems with your speech, we're seeing asymmetry, like your face doesn't look equal all of a sudden, or you're getting a weakness or a numbness in an arm or leg. Those are all really concerning signs. I would add the loss of vision to that, and a loss of balance, which can be a little more subtle and sometimes hard to pick up as a stroke.
So as these emergent patients present, I'm sure they are never routine. There's no routine day. As you said, you predict for one volume of patients coming in and have surprises. As always, these bring a different level of intensity. How has the increase in intensity of service during the pandemic shifted the evaluation and management distribution curve for you and your colleagues?
Well, as I said, the percentage of people that were really sick went up, and I think that brought an additional level of intensity. In addition to that, we're dealing with a disease that we knew very little about and still, have so much to learn about, and that adds to a level of intensity on doctors' parts and patients' part. You add that patients' families generally haven't been allowed in ERs to keep them safe and try to reduce the spread of infection, and there's another stressor. And then you put on a few pounds of PPE and a mask and a cap and a gown and raise your body temperature by about 10 degrees, and it's definitely added to the intensity during this pandemic.
And when there's diagnostic uncertainty, as I'm sure there were during the early days of coronavirus disease, talk a little bit about the emergency room physicians and staff performing extended evaluations, and what's that process? What's the impact on treatment and those serial examinations?
So I look at an extended exam where, really the tincture of time is one of the most valuable tools in our toolkit. I would use the example of appendicitis. If someone's having right-sided abdominal pain, maybe we get a CAT scan, maybe it's inconclusive, or maybe we're waiting on a CAT scan. We know certain time courses, certain things happen over a certain amount of time. I know that, over the next 24 or 36 hours, if someone has appendicitis, they're going to get, more pain, they're going to get fever, they're going to not be able to eat or drink, their blood counts will change. And it becomes incredibly important in, being able to instruct that patient in what to do. How quickly do you need to call a surgeon? How quickly do you need to do a CAT scan? And the same thing could be said with COVID, even though, again, we know a lot less about COVID than appendicitis. But I know, for example, that if I see someone on day 2 of their illness, they may need another 10 or 11 days until we can all feel really confident they're going to recover without, long-term sequelae. So it helps us in our ability to say, you're okay today, but you may need to come back in 2 days for a recheck. Someone that's on the edge or teetering, we have the option to bring them into the hospital so we can watch them for a few days and make sure that they're not going to deteriorate. So really the value of time in watching someone's condition is so important to us.
So it's the month of May, and we're certainly here in Mental Health Awareness Month. The coronavirus has presented certainly some unusual mental health challenges for emergency physicians throughout New York, throughout the U.S., and certainly as the epicenter of the crisis. We've just recently witnessed Dr. Lorna M. Breen, the medical director of the emergency department at New York Presbyterian, commit suicide. Where were you when you heard this news, and what were your thoughts on this tragic event, sharing the same role as Dr. Breen?
So I don't remember exactly where I was when I heard it. I remember just thinking how terribly tragic it was and is. One thing that I guess I thought of is that, we see a lot of death and terrible things in the ER, and, just as a citizen of the world, when you can relate to somebody's tragedy because they're an ER doctor like I am, they're a father, they're a similar age, they live on your neighborhood, it hits you in a different way. And, I definitely feel the pain and loss of everybody, but, when you can relate to somebody, it's on a different level.
Absolutely.
And I think it, made me also realize just there's nobody in this country that hasn't been impacted by this at this point. I think everybody's, struggling emotionally on some level with the seriousness and the consequences of this.
And no one greater than Dr. Breen's father, Dr. Philip Breen, who was actually interviewed, which I give him a tremendous amount of credit for this. He basically reported that she had described the devastating scenes of the toll the coronavirus had taken on so many patients, and being mindful and respectful of the patient's privacy that you have encountered. Can you describe just more broadly what you've seen with patients presenting to the ED, and can you share some of the mental health challenges specifically that you've encountered?
Yeah, again, I think as a provider, as a doctor, one of the hardest things is just the number that there's so many more people in our country that are really critically sick and that we've had to watch suffer. It's an emotional challenge to watch people suffer alone or without their loved ones.
The
Uh,
isolation is critical.
it's that's been one of the most painful things for me to watch. I've personally been on Zoom funeral calls, which
Wow.
really was so impactful and so really made it hit home. I think those are some of the ways that it's been most impactful personally.
What are some identifiable changes that you've seen over the course of the past few weeks and months with these patients as they present? Are you noticing anything different about the patients and their state of mind?
I think it's goes through multiple stages, but certainly in the beginning in March, there was a lot of people that I think were having COVID-related anxiety because there was so much unknown, and there was a much more limited access to testing and the knowledge about what was going on. So we would see people all the time, they think they had it, they had this funny thing, could that be COVID? My neighbor had it, could I possibly have it?
Sure.
And I think, as we've had some time to take deep breaths and realize that we're in this for longer than we, thought we would be initially, or at
Very much
least
so.
personally, we're in this for longer than I thought we would be. People have moved into more of an acceptance phase, and I think are dealing with some of that stress and anxiety better related to the disease. I think people are a little bit less fearful of, if somebody sneezes on me, I'm going to die. And so I think, we're seeing that get a little better.
I think the movies certainly have not helped that, and the narrative that we've seen, certainly from the mainstream media, has not helped that. And I know there's been some guidance that has been issued, even in terms of how to address experts like yourself in these type of interviews. And certainly, we're following that today, to not to add to the hysteria, but certainly add to the information where people can understand this a little bit more. So, let's be really, really blunt here. You and your colleagues in the ED are literally in the trenches, on the front line of this and all things when it comes to emergencies. First, and I should have started our program by saying this, but thank you to all of you for everything that you do and everything that you're doing every single day, certainly here in the Hudson Valley and in the New York area. I appreciate it as someone who lives in the area. I thank you for your efforts. Second, let's focus a little bit on the positive, because I know the time that's invested by someone like yourself directing the department that goes into the training and the preparedness. What did we do correctly? And specifically in preparedness in the ED, what else could we have improved? So I don't want to focus on the negative here. Tell me what we did right and what are the other opportunities to improve from here.
Sure. So first, I just want to say thank you for that appreciation.
Very much so.
I personally feel lucky, and I know a lot of my colleagues do, that, we have a job that we can go to every day and we can help people. So I look at it as an honor, and I feel lucky that I'm put in this position. We've thought a lot about, what we did well, what could go better. And I would start just by saying that nobody knew, in January, February, or March, really what the world was going to look like in May. And nobody did it perfectly. The things that we've done, I think, incredibly well is I'm so impressed by the way that people stepped up, frontline workers everywhere, from house cleaners, nurses, PAs, doctors, radiology techs. I was so pleasantly surprised that people didn't walk off their post. And, people said, I'm going to work and this is my job, and, I'm going to do it proudly. I think that I've seen tremendous number of people volunteer their time and, put themselves on the line. Personally here, a lot of members of our ER team have volunteered their time in our ICU or different parts of the hospital, and I've been incredibly impressed by that. I've been incredibly impressed by the collaboration. There were a lot of complicated efforts that had to go on to, staff a second ICU to deal with surge, to make sure that our radiology techs could be safe, with COVID patients. So just people really stepped up and worked well together, and I've been really impressed by that. And then, on a systems basis, in New York, the hospitals had to double their capacity to be able to see twice as many patients in a very short amount of time. And just watching that, and I wasn't involved with the planning of that, but just watching that and seeing what they were able to accomplish, that you could double the size of a hospital within a week. I was just blown away by, the teamwork and the efforts that went into that. And I think sharing of information, I mean, there's more information than I have time to read, and people are sharing and they're selfless with their sharing. So really impressed with that. I could go on and on. I think just people were working so well together, which unfortunately doesn't always happen in non-crisis times, but people stepped up. I think things that we could do better, and we are thinking about this because we're preparing that there may be a second peak in our area. Certainly hoping not, but preparing for that worst. I think we could do better about being organized and planning our PPE needs, about, thinking about what we're going to do with our staffing models and kind of matching our staffing to our volume. I think that, those are some of the areas that we could do better. I think as a country, I think we could do better with, really ramping up our PPEs, our testing, our ability to do contact tracing, certainly to avoid, that second peak being as high as the first.
Everyone's turned into a public health official overnight, having to manage all of this, and certainly the supply chain along the way. So I think we should also acknowledge the efforts of many of those in the area that are about to support a lot of that contact tracing, with literally thousands of people who have tested positive. And I know that there's certainly an army that's being formed, even here in New York State, currently being recruited, among those being even recent college graduates with public health degrees. So certainly we're very thankful to you and your staff for all your efforts, and certainly to everyone who's about to undertake yet another wave of effort to ensure that we understand and are better prepared for what comes next. But I'd like to refocus our conversation back to the mental health with a slight twist of sorts, because in a typical day, not that there is one, but there is a very complex issue of deliberate self-harm that you see every single day. We'll call it DSH from here on out. It certainly is pertinent for staff in the ED. How common are self-harm and even attempted suicide in terms of frequency in the emergency department?
So unfortunately, that's something, before COVID, during COVID, and after COVID that, every ER doctor in this country deals with on a daily basis. We're seeing about 500,000 cases of attempted suicide per year in this country. So it's really a very common thing that we have to deal with and, be ready for. And, as the implications of the COVID pandemic are with us, obviously the frequency may change.
Wow. So suicide is certainly a very complex, multidimensional event, a host of contributing factors. Can you share with our viewers some of the historic data of this leading cause of death in the U.S.?
Sure. So right now, about 50,000 people per year are dying from suicide. It's the 10th leading cause of death overall, but disproportionately higher in the younger population. Just a little bit further, men are much more likely to complete a suicide, but women are more likely to attempt a suicide.
Wow.
And, veterans are a population that's at higher risk. Anybody that has access to a firearm is at a higher risk for completing suicide.
And what are some of the factors relating to depression, deliberate self-harm, and suicide that you see literally every day?
Well, the majority of people that are coming in with suicide thoughts or suicide attempts, they will have a history of mental health issues, whether it's depression, anxiety, or other psychiatric illness. Other factors are drug and alcohol abuse, history of violence or domestic violence. People that are unemployed or are struggling financially are going to be at a higher risk for self-harm.
And suicidal emergencies certainly are among the most widely behavioral as well as psychiatric emergencies that really provide the basis for a lot of your ED visits. Is the ED, in your mind, the ideal clinical environment to assess these patients? Why or why not?
In a lot of ways, yes. I think from the medical standpoint, and there's kind of two separate issues. One is someone that's attempted to hurt themselves or hurt themselves. Those patients need to be medically stabilized to make sure that they're safe. And I think for that, the ER is the perfect place and probably the only place that can do that consistently and well. So, nowhere else in medicine is there a doctor that's trained specifically on, how to deal with a Tylenol overdose, an alcohol overdose, a slash to the wrist, a gunshot, all at the same time, and have the resources, to get help in that one spot if needed. So I think in that way, the ER is really the ideal place to start the assessment for those patients.
Or a combination of those. So certainly as someone presents, they may not have one of those deliberate self-harming episodes. They may combine some of those efforts, certainly if there is a greater number of activities involved in the attempt. Let's stay on that thought for a moment, and I'd like you to respond to a statement that I viewed in preparation for our discussion, which said ED staff may be well placed to prevent future suicides. What are your thoughts on that statement?
It's been shown that out of the people that harm themselves or, commit suicide or attempt suicide, most of those people will have encountered the healthcare system in some way within a very recent time period. And so what we've gotten really good at in this country is at least asking those questions when people come in for their triage. So no matter in this country, at least in New York, and I think the rules are pretty similar everywhere, but if you come in even with a splinter to your finger, you're going to be asked, have you had thoughts of harming yourself recently? And people may say no and they may decide not to disclose, but it gives people an opportunity. And if people do say yes, we have resources available. We have social workers, we have, psychiatrists, we have networks of people that can help, and we can get you to the right place. So in that way, yes, there's opportunities for us to help people. And, we just hope that the people that need the help will say something.
Yeah, I observed that even with my first telehealth visit with my internist this past week, as I was going through the preparation stages online and checking in, that those were two questions that were asked right up front in terms of the frequency of my thoughts. Specifically about being depressed, and I found that to be incredibly valuable as a screening effort to ensure that the physician that is then seeing the patient knows a little bit more about what that person is thinking intimately before they even present. And certainly none of us could read anyone's minds, but if someone is filling that out, and they are able to express themselves privately and then engage with a physician, it may be an opportunity for engagement. And I thought that was a very elegant way that this system in particular was able to screen out patients even before the conversation began. So again, we can't read people's minds, but certainly some of these screening tools, some of the triaging, perhaps will allow our physicians to be better equipped as they're encountering these patients. I want to take a step back in history. Certainly, with the emergence of SARS, originally back in 2003, we saw a lot of these early signs that we are now seeing in volume today. But my question to you is: did we see an increase in suicides back then with SARS when that originally emerged?
Sure. So there are a few points in history where we've seen suicide rates go up, globally or at least nationally. Just going back to the 1920s, really during the Great Depression, we did see a 50% increase in suicide rates. Additionally, there have been increases noted during the SARS epidemic. And it's really early to tell at this point, is that going to be something that we're going to see again? So certainly something that we need to look out for, during this pandemic.
And the patients that are presenting, those with depression, those that have made an actual attempt on their life, how do you assess them? Talk a little bit more about the technical aspects of a patient that is presenting. How do you initiate that first conversation? What are the tools? How do you assess their risk at that point?
Sure. So, anyone that's attempted to or actually has harmed themselves, it's we say ABC first: airway, breathing, circulation. So, the first thing is a medical stabilization. Are they physically safe from what they did to their body? And obviously that varies depending on what they did or what we think they did to their body. The psychiatric assessment often comes after that physical, or always comes after that physical assessment. So we use different screening tools to assess people's level of risk, level of depression. But, we ask them, do you have a plan to hurt yourself? Do you have access and a means to hurt yourself in the home? Have you ever hurt yourself before? What's your social support? Do you live with people? Do you have something to be hopeful for? A job, a family that you look after, things like that. So those are just some of the things that we're thinking about as we're making an assessment of future risk. When someone's already hurt themselves, they've really established that they have very high risk for self-harm, and it becomes a little more clear-cut.
Can you explain to our viewers the difference between a medical admission unit versus a psychiatric admission unit for these patients? What are those differences?
So in this country, we have hospitals that are really specialized in being able to care for people with psychiatric illness that are not stable from a psychiatric perspective to go home. So it's a limited resource. And what that means is that most of the time in this country, if you go to a hospital and it's deemed that you need to be admitted to be stabilized with medications or psychotherapy or a combination, you're probably going to be transferred to a regional hospital that is specialized in
Oh,
caring for you in that way.
okay.
Versus a medical admission, I think of a pneumonia, a heart attack, something like that, an infection, where most hospitals in this country are going to be able to deal with most medical admissions.
So let's discuss a scenario where a patient has presented. They have the history of mental illness. They've attempted self harm or have attempted suicide. What treatments are available for these patients?
So there's a variety. I think the mainstay that people think of would be medications, antidepressants like SSRI, for example, and psychotherapy. Talking about your psychiatric problems and working through them. And generally, most treatment is going to involve a combination of both of those things. I think other things that are really underappreciated or underreported would be things like exercise, meditation, things that you could do for your own mental health. And I'm a huge proponent of those. And in fact, they've been shown to be as effective as psychotherapy and medications. There are some more extreme measures like electroconvulsive therapy, where a psychiatrist may prescribe that for a resistant depression. And then there are things that are, emerging and being researched now, like ketamine, for example, where that's being studied for the treatment of depression and even now suicidal thoughts.
And certainly, if anyone Googles treatments for patients that have attempted suicide or have depression, you'll definitely see these ketamine clinics in operation across the United States. You have ketamine in the emergency department as an anesthetic, correct?
Correct.
Correct. So, as we're thinking about this, and this is a product that's been around for decades, and certainly was used during the Vietnam War. Have you treated patients with ketamine that have attempted suicide?
So right now, ketamine is being used at these clinics and psychiatrists' offices for depression. It's not currently approved or used for people having suicidal thoughts or attempts. And there's a big distinction. Common sense would tell you that if it works for depression, it may be helpful for suicidality.
Hmm.
And I know it's being studied now, but currently we're not using that for that indication. I do think that as time goes on and the psychiatry community adopts it, we may be seeing more of that.
No, that's excellent, and certainly it's the promise of those emerging treatments in clinical development, like you mentioned, that I really think that can help patients with those acute suicidal ideation and behaviors, and certainly equip our emergency room physicians and staff in the future to be able to address this. But there has been a recent media concern, and you shared it as part of standard practice, that those selective serotonin reuptake inhibitors, those SSRIs, may actually cause an emergence of suicidal thoughts or increased suicidal ideation. And certainly this appears to manifest itself in short-term trials, but not in those longer-term follow-ups. So really no research, as I've been able to see, please correct me if I'm wrong, supports a link between SSRIs and completed suicide. So thoughts on antidepressants being avoided in those that are at risk for suicide?
I think it's probably very complex, but there have been some links and studies showing that for certain age groups, and I believe that's the 18 to 24-year-old age group, that in the first few weeks of treatment with an SSRI, there is some increased risk of suicidal thoughts. But that on average, there's not an increased risk of actual suicides with those medications.
Okay.
I think it's really a complex issue. And, I would say anyone that's thinking about those medications, there really needs to be a detailed discussion of risk and benefits with their primary doctor or ideally a psychiatrist.
No, and I appreciate that disclaimer. I was about to say the same thing. This interview certainly is for informational purposes, and we encourage everyone who may be viewing this to contact their physician or that individual who may be caring for some of their mental health needs. I know there has been substantial evidence that antidepressants are quite efficacious in treating moderate to severe depression. That's proven. We've seen the scientific literature. And that patients who have committed suicide, when we look at retrospectively, those individuals tend to have been undertreated. So certainly for patients that are presenting in the ED, are these patients that have potentially made an attempt, are they largely untreated or undertreated in your experience?
I think almost by definition, those patients that come to the ER with an attempt on their life are going to have been or undertreated, some combination. I think it will depend on, the community, the geography, the access someone has to resources. But there's really so much that the mental health community has to offer people to try to help with depression and psychiatric illness, that I think for the most part, when people reach that stage, they've not exhausted all those options.
And certainly, we've done a great job in terms of the public service announcements. Certainly, many advances in terms of public health in destigmatizing many of these conditions in people of all ages, people of all backgrounds, and welcoming the conversation that if you are experiencing any of these difficult times and difficult challenges for these conditions, if you haven't been properly diagnosed, the process by which they can be properly diagnosed, and certainly the community supports that. I'm very interested in your answer to the following question, and just absolutely curious as to what can be done. But what do you do if someone refuses treatment? I assume there are legal, moral, and certainly bioethical considerations as a physician. What are your options at that point, and certainly what is typically done?
Well, most people, luckily, that come to the ER with, thoughts of suicide are there because they want help and they appreciate the help, and, we can help those people. There's a small percentage of people that maybe came against their will and don't want help. And the reality is that an ER doctor really cannot release a patient from the ER that they've deemed to be a danger to themselves or to someone else. And so there are situations where it can get, very complex, and sometimes a security officer or a police or, a combination of that and sedatives may need to be used to keep that patient against their will until they can get treatment. And the rules on that really vary state by state. But it certainly becomes a very tricky, like you said, ethical, moral, and legal question.
Absolutely. And so, in addition to treating the patient and all of the intensity around what may be surrounding an individual case, these are all the things that the emergency department has to deal with, and certainly the staffing that you are supported by has to deal with and consider. So I think there needs to certainly be a level of even greater appreciation. You're not only dealing with the emergent situations, you're dealing with people who have come to the emergency room for a splinter or for a refill. You're dealing with the coronavirus and the changes in volume, the unpredictable nature of the disease. But then you're dealing with the legal, moral, and certainly these bioethical considerations, and then your work really just begins because you actually have to treat a patient. So that's, to me, absolutely amazing. The multitasking that needs to go on, the consideration that needs to be given, and certainly there's much to this as the science of medicine as there is to the art of practicing medicine. And I'm certainly that to be nimble and adaptive to every situation as it happens becomes an N of one as it presents. So thank you for all that you do. As our time for the episode is nearing, let's help some of the people that are watching and give them some tangible ways that they can improve their own outlook. You mentioned before a little bit about exercising, and certainly many people are currently overwhelmed. We're all struggling to keep our families healthy, and as we've talked about personally in the last week, virus-free. This concept of social distancing certainly poses a very unique challenge for many people, but there's even a greater challenge of isolation, as we've discussed. What can we all do personally to manage this, as well as help others maybe family members, maybe neighbors, and certainly keeping our distance with what has been called acute chronic uncertainty. Are there any resources also that are available that you recommend?
Sure. So, I would just start off reiterating, we're not in this for a sprint like we thought we were. This is really a marathon. And I think just mentally preparing that this may be a long time of not being normal, and we need to go on and enjoy our lives while we're, dealing with this and, waiting for it to be over. So we all need to find enjoyment. So whether that's exercise or drawing or music or whatever, we need to do those things. We need to take time for ourselves. We need to make sure that our family and our friends and our coworkers are supported and listened to. I think everybody probably needs someone to talk to right now. So, reach out to a friend or a family if you haven't, and we're thinking about them, because it means a lot. It's meant a lot to me, for people that have reached out to me, and I know that other people would feel the same way. You got to take care of your body and your mind. You got to eat right and exercise and get, your 7 or 8 hours of sleep. Those things are, really critically important to your physical and your mental health, and they're definitely connected. As far as resources, I'm going to reference my note, but I think the major resource I would encourage people, if they need, is the National Suicide Prevention Hotline, which is 1-800-273-8255, which is 273-TALK, 273-TALK. If you're worried about somebody, please don't be afraid to reach out to them and see if they're okay, because that can make all the difference, between life and death.
So continuing on that deeply personal side of the conversation, certainly many of us have lost colleagues. We talked about Dr. Lorna Breen and her situation as a tragic situation for a colleague in emergency medicine. But some of us have lost colleagues, we've lost family, we've lost friends, and certainly some of us have seen the passing of public figures that we admire. Have you lost anyone that you've admired during this unprecedented time? And who were they? What was their influence on you or your life or your career? Can you tell us a little bit about them and your relationship?
Sure. So, everybody in this country now has been touched by this disease in one way or the other. I feel incredibly lucky that I personally have not lost a friend, a family, a coworker. And I think that goes to the value of what we've been doing to protect ourselves with our distancing and our PPE. Personally, the thing that hit the hardest for home with me was that my mother was sick with COVID, and I was calling her 3 times a day and, losing sleep, just thinking about, what that could mean, for me, for my family, for my father. So, very powerful and
No
scary. Doubt. And I feel so lucky that I've not directly lost anybody that I know.
And God willing, that trend will continue. So we certainly hope so. Dr. Cohen, let me open up the floor to you for the final word.
Just thank you again for having me on. Again, we can't hold our breath through this and wait for it to be over. We need to go on and, live our lives and find enjoyment. Please continue to reach out to your friends and family. We all need to lean on each other during this time. And I'm just incredibly grateful to the community, to our nation, for the support they've given to frontline workers. It really does help keep us going. So just so grateful for that, and really appreciate the time with you today. Thank you.
Thank you, Dr. Cohen. For the New Right Network, I'm Mario Nacinovich. To access this episode and other on-demand programming from Stealth on Health, visit newrightnetwork.com, the right voice right now. Thank you for tuning in. Stay safe and stay healthy. Welcome to the Healthcare Voice of the New Right Network. This is Stealth on Health with Mario Nacinovich.